Hi, I'm Rick Pollack, President and CEO of the American Hospital Association. Thanks for tuning in to this special announcement. COVID-19 has changed life in our country in so many ways, but it hasn't changed our commitment to ensuring that all people, regardless of background or zip code, have equitable access to the highest quality of care. The AHA created the Equity of Care Award in 2014 to honor organizations that serve as outstanding leaders in eliminating healthcare disparities and promoting diversity and inclusion. Last year, we renamed the Equity of Care Award to the Carolyn Boone Equity of Care Award. Carolyn was the first African American and the first hospital trustee to chair the AHA Board of Trustees. She was a tireless advocate for equity of care. It was an honor for me to have known her personally and to have worked with her. That's why I feel so privileged to be part of honoring her memory as a pioneer for diversity, inclusion, and health equity. We've seen how this pandemic is further exposing racial health inequities. So now, more than ever, we must recommit to address health disparities. Now, more than ever, we must harness our collective power to champion changes that will advance health for every American. That's why it's a great pleasure to recognize the winner and honorees of this year's AHA Carolyn Boone Lewis Equity of Care Award. This year's winner is Cone Health in Greensboro, North Carolina. Cone Health's comprehensive approach to health equity starts with a commitment from its diverse leadership to foster a culture of belonging. At Cone Health, physicians are required to participate in health equity courses, as well as receive unconscious bias training and education on racism. They have also successfully used race, ethnicity, and language preference data to design and implement programs that improve patients' health and reduce readmissions. The Henry Ford Health System in Detroit is an Equity of Care Award honoree. This organization has a long track record in this arena, and its leadership has implemented a system-wide healthcare equity campaign focused on improving cross-cultural communication and integrating improvements into organizational practices. And their Institute on Multicultural Health is working to develop effective and innovative approaches to providing quality care to vulnerable populations. Chatham Hospital in Siler City, North Carolina is also an Equity of Care Award honoree. This critical access hospital has shown that regardless of size, committed hospitals can lead the way in ensuring health equity. Chatham implemented staff education on cultural diversity and unconscious biases. In addition, the hospital is developing strategic partnerships with community organizations to create mentoring programs. Congratulations to all. Thank you for your unwavering commitment to achieve a society of healthy communities where all individuals can reach their highest potential for health. I know your efforts will inspire others, and I encourage you to learn more about the incredible work these hospitals are doing to advance health equity. Please visit our Institute for Diversity and Health Equity's website to learn more.
Welcome everyone to our panel discussion featuring insights from the Carolyn Boone Lewis Equity of Care Award winners. I'm Colleen Santana, President of Centera Overseas Hospital Campuses in Suffolk, Virginia, and Chair of the Equity of Care Award Committee. As you saw in the video, the honor recognizes hospitals and health systems taking action to achieve a high level of success in advancing diversity and health equity. During this panel, we'll talk with award winners about the strategies and enduring hospital operational activities they have implemented to make equity part of the fabric of their organizations. We invite the audience to join this discussion with your questions. So if you look onto the right of your screen, you can submit your questions throughout the panel discussion. After these first few plain questions, we'll move to Q&A with the audience. Now, more than ever, our communities are relying on us, and I'm so excited to introduce and highlight the work of these leaders that have created systemic change to address inequities. These leaders are a shining example for us to learn from. So first, I want to introduce Keith Stinson, ED Director and Emergency Preparedness Coordinator, Chatham Hospital, Siler City, North Carolina. And we have Laura Vale, Director, Health Equity, Cone Health, Greensboro, North Carolina. And we have Dr. Kimberly Dawn Wisdom, Senior Vice President of Community Health and Equity and Chief Wellness and Diversity Officer, Henry Ford Health System, Detroit, Michigan. So let's get the panel started. So for all, data-driven care delivery is an essential part of understanding and realizing equity of care. Collecting race, ethnicity, and language preferences is step one. So let's talk about how each of you are leveraging this data to reduce disparities and improve outcomes to help the audience grow in our own journeys. Please share with us one key strategy for how you use patient data to address and identify disparity for your community. So let's start with you, Laura.
Sure, thanks, Colleen. At Cone Health, we stratify our data by race, ethnicity, and language. And so one thing that we like to use that stratification for is when we're looking at preventive screenings. We do have disparities across the board in our screenings. And when we looked at all of this to try to improve on this, what we saw was that for our Asian population, there was the greatest disparity in colorectal cancer screenings. So we thought about that, and we thought that really didn't tell us what we needed to know. Asian is a large category with a lot of people groups and a lot of language groups within it. So we got more granular. We stratified that bucket again, that demographic, and we were able to see that it was actually our Vietnamese speaking population that had the greatest disparity. So it really, by stratifying and then by getting more granular and stratifying again, it really gave us a sense of where should we start this work. So we need to keep working. We need to work on this for all of our populations that are experiencing disparities, but we needed to know where do we start. And so stratifying was a way that we were able to determine that.
Great, thank you.
Yeah.
All right, Keith.
Chatham Hospital's approach was looking at patient access when the patient arrives to the emergency department to ensure that we obtained adequate and correct data on our patients. Using race, ethnicity, language preference, and payer source, we looked to strive to ensure that patients seeking emergency services was equivalent to pre-COVID-19 volumes. As COVID-19 has impacted ED volumes, the Chatham Hospital Emergency Department has not returned to our prior volumes. And so we wanted to make sure that there wasn't a disenfranchised population that was not seeking emergency services. Thankfully, and looking at the data back in 2019 at this time frame, as well as our post-COVID initial responses, we haven't seen that there's a disparity amongst any specific population, just an overall decrease in our volumes. This is a promising and supportive report, in that we have not identified a patient population that remains at risk. We are meeting that need.
Great. Dr. Wisdom.
Thank you, Colleen. At Henry Ford Health System in Detroit, we embarked upon a journey to address the collection of race, ethnicity, and primary language. And we embarked upon that, getting that information via self-report. So we have over many years found various mechanisms to collect that data so that we could then stratify the data based on race and ethnicity. And very specifically, we called it We Ask Because We Care. So we did a campaign around that. We also collect very specifically, we have a large Latina population, like Latinx, as well as a very large Arab American or Arab world population. So we asked very specifically around ethnicities related to the Hispanic or Latinx characteristic, as well as Arab American. Then with that data, we stratified the data, and what we initially did, took all of our quality metrics. So we wanted to have something that was part of what the system collected already, and we began to stratify that data. Where we found differences and we found very significant differences in certain parts of our organization for the African American population. Then we identified those disparities, then established teams to address hypertension and diabetes, and those were the areas that were most obvious in those initial quality metrics. We established a team to help address in closing those gaps using a PSA or Plan to Study Act process, small tests of change, and then we work to systematically close those gaps through that process.
Great, thank you for each of you sharing with us. Now this question is for Laura. So congrats again on your award, Laura. With all of the foundation that was built at Cone, it was evident that health equity cannot happen only within the walls of the hospital or clinic, but also requires strong partnerships with community organizations. I was particularly impressed with the work around leveraging hospitals as catalysts for racial healing in the community that you had talked about in the podcast. But hey, tell us how Cone Health leveraged its standing in the community to respond to at-risk populations during the COVID-19 outbreak.
Yes, so I think with COVID-19, teamwork really has come into play like maybe we've never seen that before. And so really working with our community partners, understanding that they bring a great amount of trust and just understanding that there is racial healing, right, that is going on in the midst of something that's exposing, terrible inequities. And so, so as we all came together, in the very beginning, we reached out to our community. We didn't have enough PPE. And so we reached out to our community. Our community responded with complete generosity. And so, so that was kind of our first interaction in COVID-19 with our community. And then we shifted internally and we said, we can't do this alone. And like you said, we can't do this inside the hospital walls. So we quickly reached out to our community partners and tried to assess the needs and the needs that they were hearing. And I think one thing that was really helpful for us is we weren't the big brother in the story. We were a partner, and sometimes as a health system, you can get that shifts, right? And you can get in that situation. And so it was super important for us to enter in as a partner and really listen and convene conversations. And then operationally to see, okay, we need to stand up testing and we need it in our under-resourced communities where people might not have access to testing. So, so we quickly set that up and, sometimes we had the trust and we could go in and leverage that trust in some situations. And in other situations, it was our community partners who held the trust. And we say, we go in on borrowed trust at that point. And so just really working as a team, working really with our community partners in a whole different way, allowed us to respond to some of the inequities that we were seeing.
I was reading about some of the work with the pastors in the community to help leverage trust. Do you want to add anything else about that, Laura?
Sure. One of our churches, we had so many churches that reached out. We ended up not being able to offer testing at every single church, but one church in particular, early on, before we had offered our first testing, they came back to us and just said, we will be an anchor for you. So we had not even tested there once, but they trusted us. And that is a testament to some of the healing going on in our community, racial healing, that has taken a long time. We were part of a court case back in the 60s that settled that if people had taken federal funds, they were going to integrate. And so that's a part of our history, and it's a part that we've apologized to the community for, and it's a step, and this relationship with these pastors of these large African American churches, it really was evidence that this healing is moving forward for us.
Great, thank you so much for sharing that. Yeah. So this question's for Keith. The committee was so impressed with the work from Chatham Hospital, overwhelming response from our team to honor and highlight your work. So it shows that regardless of size or amount of resources that the leadership has around health equity, we can be effective. So share with us, how did Chatham Hospital get started with its commitment to health equity? What steps were critical to Chatham Hospital's success that other small hospitals or any hospitals can learn from?
Chatham Hospital, located in Siler City, North Carolina, is in a rural community. We're a 20-bed critical access hospital. And in 2018, Chatham Hospital's president signed the AHA Pledge for Equity. To be honest, this was the first step in the commitment to say we are going out through this. This action signified that we were committed to striving to achieve goals in the 4 areas of the pledge. As part of a larger healthcare organization, UNC Health, Chatham Hospital formed relationships with area leaders in healthcare and applied lessons to our rural critical access hospital. As a small hospital, our leadership team functions in various roles. A successful small hospital finds ways to incorporate methods for health equity into programs they are already conducting. For example, if a hospital is working on improving customer service scores, can you add training on how to have conversations to collect demographic data? Or if you're looking at your readmission rates, which at our facility, we usually only readmit about 3 patients a month, can you evaluate those readmissions not only on if their appointment was made for follow-up, but on social determinants? Chatham Hospital used A3 thinking to set a course for the year. This provided the foundation of goals and action items that we could implement an action plan. Such methods ensure that our team stayed focused and was goal-oriented. Each year, Chatham Hospital selects new goals and actions based on our prior year's success. Smaller hospitals also need to have a relationship with the community services and agencies around them. Every 3 years, we participate in the Chatham Health Alliance Community Health Needs Assessments. In addition, we have representatives from the hospital that serve on the various subcommittees from that organization. These relationships ensure knowledge is shared of services that are provided and allow for resources to be shared. Another area is to celebrate. You need to celebrate when you achieve goals, when you identify new projects or areas of focus, or when you determine that the data you've collected says you're meeting a need. Take time to celebrate, keep focused with specific goals and action items, have relationships with other area leadership, and have a community partnership. That's our way of success.
Oh, thank you, Keith. Okay, this question's for Dr. Wisdom. So Dr. Wisdom, I've loved learning about the depth of work and the dedication Henry Ford has had to health equity. So one thing that stuck out to us at the committee was your work regarding the Community Resource and Health Literacy Center. Can you share with us why is it important to your health equity strategy?
Sure. Thank you for asking that question. And many of our efforts, we try to align with the culturally and linguistically appropriate standards or the class standards out of the Office of Minority Health. So one of the areas is to focus on the ability to provide us tools and have the ability to communicate, whether it's patient education, information, or in other ways, to diverse populations so that everyone has the greatest opportunity to achieve their greatest health outcome. So initially, we had an effort, it was a bit more organic, I would say, many, many years ago, where we had people that would evaluate patient education materials from a health literacy standpoint. And over the years, we realized as people became more aware of the need for that and the requests became greater, it became important to establish actually a department. So we don't have a center, but we have a department that focuses on health literacy and patient education, where the team members of that department work every day to look at materials to ensure that they are at a appropriate reading level and that they're culturally competent in as many ways as possible. So now it's a very deliberate, very intentional, and it's part of our infrastructure for our organization. So it's not something that's dependent on a few people that we have that may volunteer to do it, which started off years ago, but now it's much more systematic and is actually functioning as a department. So people any department then can reach out to this team. And they're also part of our patient education, pursuing equity in patient care, what we call PEPC. So they're a member of our group as well. And we continue to find ways to improve the way that we deliver care and education to the diverse population.
Great, thank you. Okay, so this question is for everyone. Now, it's a pretty open-ended question, but we really want to learn, what are you most proud of when you take a breath and look back at the multiple years of work, or share with us 1 or 2 wins and best practices you would like to share with the audience, perhaps something that would help those just entering the space, or talking about something that was the most effective thing that you've done in your organization to drive outcomes. Again, open-ended question, but just wanted to hear from all of you. So again, we'll start with Laura.
Thanks, Colleen. That's a great question. We've been at this work since 2014. And so as I take a look back down the road and think, what am I most proud of? I think it's really when we have been able to reduce or eliminate a racial health disparity. And so that really, for me, I think just tops the list. So we've been able to do that in our cancer center, and just recently we set up a transportation department to be able to take care of our cancer patients and make sure they weren't missing appointments. We've been able to do that in our hypertension postpartum readmissions for our OBGYN service line. And I think really those are big things, is taking on those tenacious racial health disparities. And that's probably what fills my heart the most, is when I turn around and see that we can do it and we will do it.
Thank you. Okay, Dr. Wisdom, let's hear from you.
Yes, I would say it's been a journey for us at Henry Ford Health System. And I'd say what I'm most proud of is that people have stayed very engaged throughout the journey. So whether it's working at a programmatic level, we have many programs in place to close disparities gaps. If it's at the practice level, we have a very robust effort called Network Detroit, where we eliminate health disparities gaps and address mortality and maternal mortality. And we've seen great outcomes, as one of my other colleagues from Cohen Health mentioned, in terms of closing those gaps and seeing our infant mortality rate driven down. Also, policies. We have influenced policies at the state level around community health workers and having health plans embrace community health workers to have sort of a sustainable model in terms of how do we continue to decrease health and healthcare disparities. And then I would say, lastly, the partnerships. I know one of my other colleagues mentioned faith-based partnerships. We have over 200 partners that we've worked with for many years. And without our partners, we could not achieve nearly the outcomes that we have for our patients or for our communities. So just really excited to continue the work, and most proud of my colleagues that stay pretty engaged. And then we have newer colleagues that are now very interested in becoming more and more involved in the health and healthcare disparities area.
Great, thank you. Keith.
So being a younger organization in the pledge, the staff engagement and involvement and wanting to learn new things and apply what they've learned has been really rewarding and heartwarming. On the patient care side, I would say it's advocating for resources, particularly with COVID-19. Again, trying to get assets to a rural location that's in need. We were able to do that along with our county partnerships to have a testing center here on campus. And then we just recently opened a maternity care center, a 5-bed unit. That's not something that you hear of in a critical access hospital starting. It was 28 years ago when we closed down. And so to identify a need in the community and create something along that line and risk for the hospital financially has been really rewarding. And we're here for the community with it.
Thank you all. So this question's for Dr. Wisdom. It was evident to the award committee the commitment Henry Ford has to diversity in the board and leadership. To help our members that are getting started in this work, share with us how Henry Ford Health System fostered a diverse board. And then with diverse board representation, how has the board's work transitioned to their support and expectations around diversity, equity, and inclusion?
Right. Well, we are very delighted at Henry Ford Health System to not only have a diverse system board, but we have many other subsidiary boards that are diverse as well. And for one, because we have a deep relationship with many leaders and luminaries within our community, we're able to identify key people, whether they're from academia, the business world, to engage on our board. So, and we very kind of affectionately say that once you're on one of our boards, rotate you around to another. So, when you've engaged on a board, you're on a board for life in many ways. And the beauty of that is we have tremendous board members that volunteer, but also institutional memory that many of these board members have. It helps to ensure that we continue to move our efforts forward. In terms of your other question, can you repeat that again, related to the diversity of the board element?
Sure. And so now that you have great diverse board representation, how's the board's work transitioned to their support and expectations around now the work, right, around diversity, equity, and inclusion?
Right. Well, part of that institutional knowledge is that board members don't forget. So when you provide experience for them, such as most recently even taking them through a diversity, equity, and inclusion exercise and experience, they remember, so that when elements or when decisions need to be made around diversity, equity, and inclusion, that they ensure that what we said we wanted to do or what we agreed to early on, that we have that accountability around those elements. So just delighted to have the board members that we have, and really appreciate their commitment, but they keep us accountable, and they also push the envelope. And because of their commitment, we're able to continue to grow and learn and expand our ability to improve the health of the community, health of our patients, as well as the health of our employees, because our board members stay very vigilant in keeping us.
So now we'll take questions from the audience. So as a reminder, you can submit your questions to the panel on the side of the screen. Great. So we'll start the Q&A session. So I'll start with Laura. You described how Cone offered testing in under-resourced areas and being mindful of who holds the trust in the community. Tell us what you're anticipating with this vaccine distribution just right around the corner.
The vaccine distribution is certainly the conversation of the day. And yesterday there were 3 different phone calls, right, that I was on that are all about the vaccine. And so I know this is something that we're all tuned into. I think what we anticipate is one of the calls I was on last night was our local group that they're committed to racial health disparities. It's a community group, and they were proposing that we have a Zoom platform type call late January that is a judgment-free and just allows people to hear the history, hear about the Tuskegee studies, hear some of the apprehensions, and also to hear from public health experts and the health system, as to why we recommend the vaccine. And so I think we anticipate that these will be hard conversations, honest conversations. And so to double click on something, said earlier, just that we really have to be a convener and a listener in order to be able to respond appropriately to their concerns, to our community's concerns. We know that, as it falls along race, ethnicity, and language lines, we know that we will need to spend a lot of resources, time, and energy having our translators work on getting all the documents and all the languages that we need. That education is so important, and we don't all speak English. And so really recognizing that and being responsive in someone's language and like Dr. Wisdom said, really culturally appropriate. I love that she has an advisory team that works on health literacy. So those are things that will be, will keep us busy in January as we prepare for this.
Thank you, Laura. So Dr. Wisdom, right before the Q&A session, you were talking about the board's DEI experience. And I think the audience wants to learn more of that. So give us a sense of, what that looks like in particular, like how long was the experience, what were the components of the experience, just so we have an opportunity to replicate your best practice.
Absolutely, Colleen. Thank you for that question. So as I've shared before, Henry Ford Health System has been on a journey, and we started off with the Healthcare Equity Campaign. And one of the key learnings from that Healthcare Equity Campaign was that we started in about 2007, was that we didn't engage our senior leaders as much as we could have across the entire enterprise. We have 33,000 members of the organization, and we didn't include board members in a very robust way. So that was one of the lessons learned, and that's why I'm so glad we have the opportunity to share with other organizations now, because we've made our share of mistakes, and we look back and there are a lot of lessons learned. So we're so delighted to share them now. So one of the efforts was to ensure that we had board members that were not engaged in just in understanding what we were doing, but actually began to have some experiences. So unconscious bias is one of the key elements that we know that will help to close the health disparities gaps and help us achieve health and healthcare equity. So our efforts were to engage our board around an experience. And we don't say training for any of our entities, whether it's our clinical entities or our boards or our senior leaders. We talk about training / education, because it's an ongoing effort. It isn't a checkbox. It isn't something that you do one time, you say we're good, and then move on. It's an ongoing, iterative, lifelong learning experience. So during a retreat that our CEO, Wright Lassiter III, called, we had all the board members engage in, we probably spent 3 hours over, in part, right, the topic around unconscious bias and our diversity, equity, inclusion, and justice work plan or strategy that we're working on. Then we had a guest speaker that came in, that one of our luminaries in our community in the diversity space outside of the organization. And we had a bit of discussion around she shared. Then we broke up into small groups, and we each had the ability to talk with our, when I say each, meaning senior leadership, up in small groups with subsets of the board. And we had a chance to go a little bit deeper in terms of what we're developing as our pillars for our diversity, equity, and justice space. So we had a chance to talk about social injustice and racial inequity. There was another one that talked about a bit more about the diversity and inclusion in terms of driving a culture. Another one that addressed disparities gaps, health and healthcare disparities gaps. And another one talking about our community partnerships, driving community health and well-being through efforts related to even our supply chain, which are key. So we will continue on an ongoing basis to engage our board, not just in information, but also with engaging them very deliberately in the experience. But also we had about 2,200 members of our senior leadership, of our leader, we call it our all leaders group, met in February of this year. And we went through a very deep experience related to hearing the Pillsbury Theater troupe shared about a 45-minute presentation, and then we broke into small groups and again went through an exercise in terms of understanding more about unconscious bias. So we have plans for 2021 that we're going to continue this experience with our team members and then go deeper so that all 33,000 members of our enterprise will be exposed in an initial basis and then in a more ongoing basis.
That's a very helpful. Thank you, Dr. Wisdom. So, Keith, when you're looking at the culture of safety, it's everyone's responsibility. And so when you're looking at the culture of equity, I'd really like to learn more. You had brought up engaging the whole staff at Chatham. So what expectations did you set? What skills or workplace tools did you feel were most helpful to the staff? How did you engage them? What's that look like?
So the approach that we took at Chatham Hospital was multifaceted, in that first, in their yearly evaluations for employees, we identified diversity, equity, and inclusion training to be one of those elements that we wanted to have specifically identified on our evaluation tools. We set goals around participation with each of those elements. And when I say multifaceted, ultimately in person as well as online methodology. Individuals learn different ways, and so we wanted to ensure that there were opportunities for staff who like the engagement and interaction with others and their peers and real life situations to have that opportunity. And then for the ability to do online modules and training in that regards, watching videos, answering questions, having that interaction, and pulling those interactions and videos into some of the real life experiences as well. So the approach ultimately being to have a diverse program that meets the needs of individuals, tying it back into evaluations and making it so that it was significantly making that personal connection between why we're doing what we're doing and learning about unconscious bias with application.
Great. So we heard about engagement with the board members, leaders, and staff. Let's talk about engagement with the medical staff. So any tips for the audience on things that you've tried in your organizations or things that you've tried and maybe didn't go well, and then how'd you turn that around, lessons learned moving forward? Anything that you could share about medical staff engagement?
Sure. I would be glad to share something related to engaging medical staff. And we've been working in the equity space very closely with our Women's Health Services Department, or OBGYN department. And there was an opportunity to address maternal mortality. We know that we see disproportionately adverse impacts in women of color related to maternal death. So we formed a group. We actually invited some external community partners, and we had the chance to talk about how would we shape an effort related to addressing maternal mortality. And one of the key elements that came up from our medical staff was that they wanted, again, the unconscious bias training, because they knew as they read about Serena Williams and the PhD, the doctor from at CDC that passed away from a maternal complication, they really wanted to address biases. And they felt that those are, could be prevalent and something that could be certainly mitigated. So the decided on unconscious bias training. Now the department is about 400 people. You talk about everyone from the environmental services team, which are very important and need to be trained, as well as the neonatologist, respiratory therapists. So engaged, get the approval through many steps to have the entire 400, all 400 members of the department trained, which is a significant commitment because you're pulling these people offline. There's a little pre-work, but you're pulling them offline for hours. So my hat's off. I just can't underscore enough. I know others have talked about their amazing team members, that when people show up in that way, realizing that it's going to impact the revenue that will be generated during that time, but realizing the commitment to this area is that key. So we're in the midst of delivering the unconscious bias training, developed a whole curriculum, unconscious bias training to our clinical team members, and are evaluating that process in the midst of evaluating that process as well. But we're rolling that out, very excited about it. We'll hope to over time share that with those of you across the country as well.
That's a great example. Laura or Keith, do you have anything you want to share?
I'll just share that, we have the example of it not being successful back in 2016 when we took the idea that we would offer cultural competency training to the medical staff services. And, it was disappointing. And later that year, when we were going to apologize to our community for past discrimination and segregation in healthcare, we engaged the medical staff again. And at that point, they were ready to be engaged. And then we came back a few years later and brought a lot of data, patient satisfaction data, quality outcome data, showed them the disparities within our health system, and really asked, could they support cultural competency training? Kind of just came back again. And this time we were more prepared with more data and internal data. And I think that really spoke volumes to our medical staff services, and they aligned. And now we have the requirement for medical staff training around health disparities, racial equity, any kind of cultural competence topic.
At Chatham Hospital, our goal has been that our providers are part of our healthcare provider team. They ultimately participate in all of our training modules and interactions so that when we're working on a project, they are actively engaged members, so we can build those tight connections. And we luck up that our chief medical officer is in part of the county with regards to equity and inclusion. And so he has actually been a big supporter of the program, as well as encouraging his providers to be right there beside us in classrooms and interacting with us as we have our discussions. While they're not our physical staff and they're contracted employees from UNC, having that larger connection with the healthcare system and being in a system goal of ensuring that we are providing equity of care has enabled us to pull upon that as well.
Thank you. With 1 minute left in our Q&A session, just following suit behind Rick, what question maybe I haven't asked that you would like to answer? Great. Lasting comments.
I don't mind. I'll open up. One of our lessons learned recently is bandwidth. I am the director of emergency preparedness as well as the emergency department, and the COVID vaccine is now hit. So ensuring that you have staff who are identified to continue on with the process, who are built ready to step in when someone needs to step out to ensure continuity is extremely important.
Great. Thank you, Keith. Laura or Dr. Wisdom?
Go ahead, Dr. Wisdom.
I would say the opportunity, what's key is to leverage the triple pandemic in a way that we can, address equity in even more robust ways that, and really capitalize on accelerating exponentially our efforts as a result of the triple pandemic.
Excellent. Thank you.
I would just say keep your eyes and ears open. Really listen to your community, really listen to those partners, engage them. They have a lot of knowledge. We often talk about how we pay consultants to come in and help us. And really our community, they have the knowledge that we need in these situations. So like Dr. Wisdom is saying, in order to really turn this around and make this a positive, we've all pivoted and done different work this year because of COVID-19, and really to turn this around and make it a positive for our communities and our medical staff and our caregivers. And at the end of the day, it is about equity of care. We're all committed to seeing these outcomes, the health status and the health outcomes, be something that people experience with equity.
Well, I wanted to thank each of you and our panelist team here for this thoughtful discussion. You have empowered each of us. I also want to thank you for the intentional efforts and outcomes from years of activation in the space. I know some of you have been doing this over a decade. So you've demonstrated the true sense of patient-centered care by showing us effective strategies that are ingrained in your organizational culture. Much like what Nico and Nympha shared with us in the earlier session, that's foundational and key to success. So in 2015, the AHA launched a national call to action to eliminate healthcare disparities by accelerating progress on data-driven care delivery, diversity and inclusion, along with cultural competency strategies and effective community partnerships. And it was an honor to honor each of you here on the panelist team for winning and as honorees for 2020 Equity of Care Award. And so for the audience, we want to continue to encourage you, if your organization hasn't already checked out the Institute for Diversity and Health Equity for resources. So that's ifdhe.aha.org. We hope that our panelists gave you ideas and inspiration for your organizations. And I wanted to thank you, our audience, for joining us today, as well as your work now and in the future around diversity and health equity. We are looking forward to your future applications and hearing about the impact you're making in each of your communities.